Hello, this is Omar Shaheen. I'm an internal medicine intern at Riverside Community Hospital in Riverside, California. Thank you for listening to my case presentation titled From Corona to the Coronary. I'd like to start off with a case introduction. Coronavirus disease 19, abbreviated COVID-19, is a viral illness that is mainly spread by respiratory droplets. As such, respiratory illness is a common manifestation of the disease. Another notable consequence of COVID-19 is a hypercoagulable state, the optimal treatment and prophylaxis of which is still to be determined. The COVID-19 induced hypercoagulable state can cause arterial thrombosis, resulting in an acute coronary syndrome. The damage to the myocardium can then manifest as myocardial conduction abnormalities. This is a case where a patient with COVID-19 had suffered a myocardial infarction and also had electrocardiographic disturbances during his hospital course. The patient was a 64-year-old Caucasian man with a past medical history of uncontrolled diabetes mellitus and hypertension. He presented to the hospital with weakness, shortness of breath, and fatigue. He was found to be in a state of diabetic ketoacidosis and had a positive coronavirus 2 SARS antigen test. Initial serum troponin was 4.18. Electrocardiogram was negative for acute ischemic changes, but was significant for a corrected QT interval of 592 milliseconds. The patient was not on any QT segment prolonging medications. He was admitted to the intensive care unit secondary to acute hypoxemic respiratory failure, and he did require a period of mechanical ventilation. His myocardial injury was treated with appropriate medical management. On day 25 and day 26 of hospitalization, his overnight telemetry monitor was significant for multiple conductance abnormalities that included bradycardia to a trough in the range of 30 heartbeats per minute, multiple episodes of non-sustained ventricular tachycardia, and sinus pauses that ranged from 7 seconds to 15 seconds. Decision was made to place patient on transcutaneous heart pacing. During this time period, repeat serum troponin was measured at 62.8. Repeat EKG was absent for acute ischemic changes. Patient's family declined heart catheterization, and the patient was again treated with appropriate medical management. Echocardiogram during this episode showed a left ventricular ejection fraction estimated at 60% and absent regional wall motion abnormalities. He was discharged in stable condition after a total of 53 days of hospitalization. My first discussion point is that our patient was a male patient, age 64, and he had a history of diabetes mellitus and hypertension. All of these are risk factors that may have contributed to a baseline coronary artery disease. The arterial hypercoagulability state caused by COVID-19 in combination with his baseline risk is a leading differential cause of his myocardial infarction. The patient had 3 separate episodes of elevated serum troponin beyond the 99th percentile of normal during his hospitalization, and this is depicted by my graphical representation on my poster. None of these episodes were associated with acute ischemic changes on electrocardiogram tracings. This is diagnosed as a non-ST segment elevation myocardial infarction. Our patient had a severe COVID-19 viral infection as evidenced by his prolonged hospital course requiring mechanical ventilation and complicated by multiple cardiac events. The in vivo inflammatory response to the severe infection could have increased the risk of an acute rupture of possibly pre-existing atherosclerotic coronary plaque, causing a type 1 mechanism for his non-ST elevation MI. The other possibility is a type 2 mechanism of a non-ST elevation MI, where the myocardial oxygen demand in the setting of severe viral infection exceeded the supply of oxygen, which was further decreased by our patient's acute hypoxemic respiratory failure. I would like to note that peak serum troponins reached the 20s on the first episode and the 60s on the second episode of the myocardial injury, and this suggests a fairly large demand-supply mismatch. Lastly, I would like to discuss our patient's QT interval on the admission electrocardiogram. Normal QT interval for a healthy man is less than 440 milliseconds. Our patient had a prolonged corrected QT interval of 592 milliseconds. He presented with myocardial infarction, which could explain the damage to the heart's conduction system. Similarly, later in his hospital course, he had other episodes of electrical disturbances that corresponded to a myocardial infarction event. Once his myocardial infarction was medically managed, he no longer required artificial pacing, and the temporary transvenous pacing was removed. The full extent of the tissue damage that COVID-19 causes is still under investigation, and I would like to propose a further step of the possibility that COVID-19 directly damages the conduction system of the myocardium independent of infarction-related disease, and this would need further study. Thank you for listening to my presentation.